Welcome. Hello, everybody. Welcome to the Worcester Senior Center and our Distinguished Speaker Series. A few housekeeping notes. Please silence your cell phones and put them on vibrate. Please, everybody, do that for respect for our speakers here. Bathrooms are located through the center doors, straight ahead. Notice the beautiful handcrafted pumpkin centerpieces created by our talented staff member, Shirley Lyon. Thank you, Shirley, for loaning us your collection. Speaking of crafts, please support our craft fair on Tuesday, November 26th. Details about the craft fair are on the reverse side of your flyer on the table. Other upcoming events include our Veterans Day program, which will be held on Thursday, November 7th, and a stroke education workshop with UMass Neurology program on Wednesday, November 13th. Thank you to our sponsors, Vascular Care Group, Fallon Health, Regal Care, and the DA's office. Thank you, Lisa, for bringing this wonderful program to our attention. Please welcome Lisa Jordan, Office Manager of the Vascular Care Group.
Good morning. Can you hear me? Thank you so much for including us in your speaker series. We're very excited to be here. As Suki said, I'm the manager of the Worcester office Vascular Care Group. We are the largest private vascular surgery practice in the country with over 13 locations throughout Massachusetts, Connecticut, and Maine. Joining me today, I have Dr. Hector Somoza and nurse practitioner Ginny Cross. Dr. Somoza is a board-certified vascular surgeon who has been practicing since 2006, and he covers a full spectrum of vascular care, including aortic aneurysms, carotid disease, wound care, and venous disorders. Before joining the Vascular Care Group, Ginny served as a family nurse practitioner for the Harrington Physician Services. So at this time, please let me introduce Dr. Somoza.
So anyhow, thank you for coming. I mean, this sounds like you have a great day ahead of you here. I mean, I'm listening that you have all these plans scheduled for you. But so I'll try to keep sort of the boring part quick and out of your way so that you can be on your way to the fun part. So this is supposed to be a talk about vascular surgery and what it is and what it means and what we do. And I figure that it's just extraordinarily difficult for us just to cover what vascular surgery is because we do a lot of things, right? I mean, we cover arterial disease and venous diseases, and we help patients with dialysis access, lymphedema, and some other hereditary and congenital diseases. So it'll probably take, a whole day just to go briefly through all of this. So definitely within an hour, I decided that it was probably going to be best if we talk about what we see the most of, which is lower extremity stuff, right? Lower extremity conditions that affect most of our patients. And that's going to be, so this talk is mainly going to be limited to lower extremity arterial disease, venous disease, and something new that we're bringing up to everybody's attention is that as vascular surgeons, we take care of all of the arteries and veins, but more recently, we've also all of a sudden found ourselves taking care of knees, like knee pain stuff. So I didn't know, when I was in school and training that someday I was going to be taking of knee pain. But we'll demonstrate how that sort of fits into our repertoire of things that we do. So a lot of people always ask, so what is it that you do? And so I decided to throw that slide there just to say, well, as vascular surgeons, we take care of all of the arteries and veins in the body. The one area that we do not take care of is the heart, right? Because they have cardiologists and cardiac surgeons to do that. And the brain, because they have neurologists and neurosurgeons to do that. Everything else, any other part of your body, if there is a vascular condition, we'll be the ones responsible for taking care of. We also help with diagnosing these conditions. We recommend the appropriate medical or surgical treatments, and we do those procedures, minimally invasive and open surgical procedures. And we also manage and take care, and most importantly, follow up our patients. One of the things that distinguishes from all other all other medical specialties is that we actually follow our patients for life. So once you have this problem and this condition, we will be the ones that will be following you forever, as this condition requires follow-up. But as I said, I want to really spend more time talking about what we really see a lot more of in our day-to-day. And number one is PAD. You may have heard of the term, right? Peripheral arterial disease or peripheral vascular disease is nothing other than commonly called just hardening of the arteries. Now, this hardening of the arteries is when you develop this lesions and plaque inside of, let's see if I can point here. Oh, it doesn't show that. Anyhow, so these lesions and plaque, all this yellow stuff that accumulates inside of the lumen of the artery. And over time, it just progresses and gets worse and sometimes complicates things because this plaque can rupture, this plaque can form clots, and then obviously other problems happen. PAD is extraordinarily prevalent. That means that a lot of us will have PAD, and a large number of us will actually have complications of PAD throughout our lives. As you can see here in this pie chart, I mean, we're really seeing or treating a very small part of the whole population that suffers this condition. The most concerning part is those in the green, which are already having symptoms and they are going untreated. So those are the ones that we really need to raise more awareness about so that people can understand and pursue treatment and talk to their doctors. Now, who has PAD? Well, as you can see here, this is a disease of aging. So as we all age, no one will escape this. Okay, by and large, every single one of us will have some level of PAD as we age. Risk factors, well, we understand that, you know, as I said before, this is an aging condition. Sex, mostly males. Males have a higher incidence of disease as opposed to over females, but females do suffer from it as well. Obviously, if there is a hereditary or genetic condition, family history, if you come from a family that had suffered from atherosclerosis and complications, heart attacks, strokes, difficulties with circulation in the legs, well, guess what? You are more likely to have it, okay? And there's really not much that you can do about it because it will be in our genes, okay? Of course, cholesterol, high blood pressure, other risk factors like diabetes, all of these contribute to the formation of this hardening of the arteries and blockages inside of them. And as I put that, you know, picture there that escaped me, it's just this guy, obviously smoking is never good for you. So what is the spectrum of vascular disease? Well, on one end, at the very end, you will have, well, the people that have buildup in the arteries, but they don't know they have it because they have no symptoms. Then once they start, this blockages build up and start limiting blood flow, then patients are going to start having difficulty with their legs. They're going to have pain, usually when they walk. It's an exercise-related symptom. Because when they're resting, they should not have any pain because blood flow should be sufficient to keep you pain-free. But once you start exercising, then things in your muscles are going to start aching and hurting and telling you that something is wrong. And obviously that will move through the spectrum where you have only pain when you walk, to pain at all times, to discoloration and ulceration and gangrene. And the worst thing that can happen is that then you lose your limb. So as I briefly mentioned before, claudication is sort of the lingo, right? This is the term that we use, and you will hear about this. It basically means, it comes from the old Greek limping, to limp. And it basically means that your muscles in your leg, as you're exercising, they don't get enough blood flow, they don't get enough oxygen, so the muscles don't like that and start aching. And this ache causes you to stop walking. So you have to stop and rest before you proceed. When it gets more severe, then this is when you see changes in temperature, discoloration of the skin. As you can see there, you would see who would say here, which leg has the problem, the nice and pink one or the one that's pale? The pink one is the one that has the problem. People say, why pink? You know, it's supposed to be white, right? If you don't have blood flow. The reality is that when the leg and the tissues get so poorly perfused and they don't have oxygen, the skin blood vessels maximally open and dilate, and all of a sudden the skin turns red, but there's really not a lot of blood flow there. So that is the one that we get concerned about. How do we test this? How do we look for this? Well, there are a number of tests that we can do with ultrasounds and little Doppler machines that you will see in your doctor's offices. And we do different types of testing. One of the most commonly used is these ABI testing, which stands for ankle brachial index measurements. That basically means we take the blood pressure in your arm, and then we take your blood pressure in your ankle. And then we get a ratio, you know. Normal perfusion means that the blood flow down your legs should be the same blood flow that you get down your arms. But when we see a difference, then that it's an sort of indirect positive test that you have limited blood flow down your legs. We obviously, after that, can do more extensive and detailed evaluation of what the blood flow is at different levels of your leg, all the way down to your toes, as that is going to be very important predictor of, you know, if there is a problem with the skin, if there is a wound, if there is gangrene, or if the patient is going to need to have an operation. Is there enough there to heal it? We can actually measure that right up to your toes, and that will be what will tell us how good that is. We do ultrasounds, and those ultrasounds can show us very colorful pictures of flow, how things are flowing, and whether that flow, the amount of flow is appropriate, and whether the pulsation, whether the flow is moving through those vessels also appropriately. We can also do 2D and 3D imaging, such as CT scans and MRIs and angiography that can show areas within your blood vessels, you know, such as this, right, where blockages are located if you compare to the other side, right? Or further up here, you see like this blood vessel has a missing part there. So that will help us not only understand the severity of the condition, but, you know, further ahead, it will actually help us formulate a plan on how could this be best treated. How do we treat PAD? Well, we move through an algorithm where it's always important to provide adequate medical treatment. We can move to minimal invasive treatments all the way to, well, maximal invasive treatments. What is medical management? It really encircles like 3 specific areas. Lifestyle modification is very important. That includes the exercise. You know, those folks that smoke, we tell them, please stop smoking. You know why, and we explain them, and we give them additional information on how bad that is. Hopefully, we can scare them enough to quit. Diet is important. Risk factors modification of those risk factors that could be modified, you know, such as diabetes, cholesterol, better blood pressure control. Those things are achieved with medications. And other medicines that can help with blood flow, such as antiplatelet medications like aspirin, for example. It's very commonly used for this. And the use of statins, which I want to just put an extra slide here for it, because statins, everybody asks me in the office, well, I take this statin for my cholesterol. Is this going to make this plaque go away? And the reality is that no, the pill doesn't make that go away. If that was true, I'll be out of a job. But what happens is that this medication not only helps you control the buildup, the continuing buildup of plaque, but it also helps you in so many ways because of their anti-inflammatory properties. So people say, oh, but I don't like taking pills. Well, no one, I haven't met a single person that does, but it's what you get out of this particular medication. And this has been proven by multiple very serious studies that have shown significant reductions in major medical conditions such as vascular events and stroke and MIs and pulmonary embolisms and DVTs and other things. And that's just by taking a cholesterol pill, right? I mean, no one ever knew that a cholesterol pill will decrease your risk of deep vein clots, for example. And they do. So this is why it's so important adhering to the medication regime. Exercise is paramount, okay? And when you meet with your doctor and they tell you, well, we need to get you enrolled in some kind of exercise program, that doesn't mean that you just go out and walk around your block and you sit down and you meet your buddies down the street and you sit there and you spend the rest of the afternoon and then walk back. It has to be a program, schedule, routine of very fast-paced walking, like you really mean it. And the recommendation is 30 minutes of walking at least three to four times a week, twice a day. If you can do that, then that will continue to push the blood flow. Even if you have some limitations, it will help create and maintain whatever open channels you have. And this is pretty similar to what would happen if, you know, anybody here preparing to run a marathon. Not me either. We are not designed to run marathons, right? There is something that says the human body is not designed to do it. But there's plenty of people that do it. And they can only do it because they train. And it isn't that training that makes them able or capable of doing that. Well, this is very similar to that. Because when we say, oh, you have to walk, you have to exercise. Did you walk? Are you walking? Are you doing it like we told you last month? This is what we mean is, if your blood flow is limited and you are depending on collaterals, you are maintaining blood flow and pressure through those collaterals when you exercise. But most importantly is that the muscles that cannot stand the exercise because of the lack of oxygen, then they become trained. They become accustomed to being without oxygen, which is exactly what the marathon runners do to their bodies. Their bodies get used to functioning with very limited oxygen supply because they're constantly burning it. So this is exactly why we like exercise. Now, let's say that these medications and these interventions are really not helping, or the disease is advanced. So what do? Well, we have to get better imaging, a better idea of what's happening. As I put there, what we do depends on the pattern of the disease. Okay, it really depends on what is happening, and we have, we will need a whole day just to talk about what are the kind of things that we can do. But for example, in the one of the most common sites that we work on is in your thigh. So this is what you see. There's a picture of your thigh bone, right? That thigh segment, where you can see an artery there, right on the extreme edge of that screen, that is disconnected and connected by a small little collateral. So with a minimally invasive approach, we can cross these lesions most times. I want to say maybe 9 out of 10 times, and then reopen it so that the pipe now can carry blood flow the way it was intended. And we can treat these blood vessels with a multitude of balloons and stents and other tools. If you've never seen stents, well, you can see them right there on the top left. We have stents that are bare metal, and we have others that are covered. We have stents that are mounted on balloons. We have a special equipment that can actually kind of file or eat away, like a typical rotor-rooter of all that blockage, and we can remove that and debulk that so that then we can treat it, open it, and make it flow better. So, this will, just what's in this slide, will probably take me about 2 or 3 hours to go through, because there are so many tools that we have at our disposal nowadays to treat vascular disease. And obviously, when this doesn't work, or when it's not appropriate, we can always resort to surgery. So, and we can do bypasses to skip over the blood segments in different ways. So, again, as I have shown there, a large number of different treatment modalities that we can use for the management of PAD. Now, I want to talk about veins, and for this, I want to hand the microphone to Ginny.
Thank you, Dr. Somoza. Thank you, everyone, for coming today and taking the interest in your own health. It will be helpful to have this knowledge. Hold on. All right, so I'm going to be talking about varicose vein disease. And just to recap, Dr. Somoza took you through arterial disease. So arteries bring blood from the heart out to our extremities. Veins pick that blood and that venous flow back up, and it brings it back up to the heart. So a couple of different systems that we're working with here. So veins, also known as venous insufficiency, it can be chronic venous insufficiency, and we can see it in our peripherals, our limbs. Typically, we see them in our legs. And when we see them in our legs, it can lead to big bulging veins that you can see, and sometimes they can cause symptoms of pain and discomfort. So this is just a picture of them, and some of the symptoms that are caused by varicose veins can be aching in the legs. It can be tired and fatigue symptoms in the legs, heaviness. Sometimes you see swelling in the legs, and it can even lead to progressive symptoms with darkening of the skin, which we call hemosiderin staining, and unfortunately that is not reversible. And if it goes on long enough, you can even get ulcers of the lower extremities. So many people first ask me, how did I get this? Why is this happening? So a lot of the times there's a family history component. Most of our patients will have symptoms that they remember seeing in their parents. Some don't remember studying their parents' legs either. Sometimes it's just lack of mobility, lack of exercise. We see some patients that are they're either wheelchair bound, or they don't get out and take care of themselves and participate in that exercise Dr. Somoza was talking about. They could actually have knee injuries, traumas, other leg surgeries that can lead to these symptoms. Prolonged sitting and standing we discussed. Excess weight does play a big part. A lot of times, especially if we have excess weight in our abdomen, it can hurt to impede that venous flow return to the heart. So it acts as like an obstruction. Smoking also contributes to it. History of blood clots, which injures the vein in the leg, and then also increasing of age. Unfortunately, we can't pass that. So these are some conditions that we typically heard about. Dr. Somoza talked a lot about heart disease and peripheral arterial disease, and chronic venous insufficiency that we don't hear a lot about is also quite prevalent. How many people here have either seen or have varicose veins in their legs? I mean, it can affect upwards of 30 million people in the US alone. So this is the pathophysiology of the vein. So veins have valves in them, and these valves are supposed to open and close when they're working correctly. And when they close, it stops the blood from returning back down towards the feet, because again, veins are bringing blood from the feet up towards the heart. They're supposed to be one-way systems. But when these valves don't close all the way, you'll see the blood goes up, and then it can trickle back down, and it just kind of causes pooling in the lower legs. And over time, these veins that are very thin, they're only one layer, they have increased pressure, and it dilates the veins. And some of the veins that are closer to our skin, that's when you start to see them as they get bigger. Oh, did I only skip one slide? I think I did. So these are some examples of some varicosities and symptoms that you might see if you have chronic venous insufficiency. Spider veins are these very superficial veins. They're not really medically dangerous unless they bleed. If they do bleed, you just hold pressure and then you come see a vascular surgeon. Then they can progress to varicose veins. Again, if you have that increased pressure in the vein, some of the superficial veins you might see that are closer to the skin. We talked about swelling in the lower legs. The skin changes, like I said, it's non-reversible, and that can also lead to thinning of the skin and eventually skin sores and open ulcers, which can be difficult to treat. So how do we diagnose it? Dr. Somoza talked a little bit about arterial imaging. We also have venous imaging. So we would first get an ultrasound that would look for the reflux, that blood going up and coming back down in the leg. So we would kind of use almost looks like a blood pressure cuff, and we would squeeze different aspects of the leg, and we're going to time the blood and looking at the blood to see if it's coming back down and how long it refluxes for. And then after you have this imaging, you would see either myself or Dr. Somoza to review it and discuss a plan. And first things first, for conservative measures, we would always recommend treatment with compression therapy. So compression stockings, there are also compression wraps. Sometimes patients have varicose veins in their thighs, and there are compression stockings that go up to the thighs, or compression pantyhose. Most people have knee highs, which are also appropriate if you only have the varicose veins in the legs. We always recommend exercise because calf contraction when you walk actually helps the venous return as well. And then we also recommend elevating the legs at or above heart level, and then weight loss if it's appropriate. Of course, conservative measures do not treat, they only help the symptoms. So for treatment options, we recommend, usually, depending on what the ultrasound shows, we have a few different types of ablations. It could be thermal or non-thermal ablations. These are done in our office. They're done under local anesthesia, so you are not knocked out for it. It's minimally invasive and not a lot of pain that goes with it, and it's much less downtime for the patient. So you actually walk out of the procedure. It only takes about an hour, and then you go home and you kind of can easily return to your regular activities as long as you're not running any marathons. All right. And these are the non-thermal. So just going back, for thermal ablation, we use radiofrequency ablation. This just uses heat inside the vein to close the vein. So we're essentially stopping blood flow. And then the non-thermal ablation, we usually use venous seal or cyanacrylate glue, or we could also use foam, which is Varithena. But in the end, the results are the same. The blood is not able to go through that superficial vein anymore. So most people are concerned at this point, don't I need that vein? Do you think you need that vein? You actually don't. There's really no long-term effects of not having that vein if it is causing you pain and impacting you regularly. We don't clearly close veins for funsies. So if patients aren't having any symptoms and they don't have any skin changes or really chronic problems with the vein, then we can just monitor it, or use compression therapy. But if it is impacting you regularly, we would recommend doing the ablation procedure. Sclerotherapy is what I do to inject the smallest of the veins, those spider veins that I showed you in that first picture. It's basically using a sclerosing agent, which is irritating to the vein, and it causes the vein to collapse and eventually just fade. It can help with the appearance of these veins, but it can also help if you're having symptoms at the site of those varicosities, such as itching or throbbing, burning. And it's done in office, and it usually takes about 32 minutes to an hour. And you walk out, and again, you go about your regular day-to-day activities. All right, I know I ran through that. I'll certainly take questions after. I wanted to leave enough room for Dr. Somoza to talk about genicular artery embolization.
Thank you, Jenny. So, this is really a new thing. As I said, who heard of a vascular surgeon taking care of knee pain before? Right? Me neither. So this is a fairly new intervention that was just recently developed in Japan, I want to say over the past 7 years or so. And this is sort of a spun of a procedure done to treat a different knee problem that was certainly treated by surgeons, vascular and interventionalists. But then they realized that this could also be used to treat the inflammation that happens in the knee, right? When there is osteoarthritis, the issue is that there is chronic inflammation right at the knee joint surfaces. And inflammation only happens in the presence of blood flow. You have to have blood vessels and blood flow to bring all the cells and inflammatory proteins and elements necessary to create the condition. So what it was designed, and what was, at the beginning, when they started taking pictures of knees, they realized that these areas of inflammation have a lot of new blood vessels. So these are not like the main knee arteries or anything like that. These are just new branches that have grown because of the inflammatory process. And targeting those smaller knee branches is what was found to be or were causing a significant improvement in the patient's symptoms, and I'll explain. This procedure is actually a very, very simple procedure. Of all the things that I do on a day-to-day basis, this is by far the simplest, less invasive, and less risky procedure that I do. So this is something that we've actually been doing a whole lot more of, because people are now learning about it and they're realizing that this thing actually works. Quick drawing here. I'm not going to get into that. That will be for your anatomy quiz later. But these are sort of the main branches that kind of feed the knee. And those are some of the branches that we focus on to find the inflammation sites. So, for example, this patient with osteoarthritis has a lot of knee pain. So we take a picture of the artery, give us a little road map, and then we start looking at how those branches, I'm going to point out to that one over there that goes across right inside of that knee joint. And when we get a very small catheter, this has to be small enough to fit into this very small blood vessel. So we get right into it. And what we do here is in this picture here, once we are inside of this vessel and we inject contrast, then we see the areas that actually blush. You see that this area of the knee here on the lateral side of the knee, it just has sort of this hazy, darker area blushing as it is this area. So those are the areas of inflammation, and what we do is that through this small catheter, we inject small, what we call microspheres. These are microscopic circular elements, material that we inject, and we just let them flow into these areas. And once we've done that, then you can see that all that blushing that you saw on either side of that knee is now gone. And the procedure is over. So what happens is, once we take care of these smaller blood vessels, we are actually depriving the inflamed area from getting more of the blood supply that is bringing inflammatory cells, inflammatory proteins, all of the things that are needed to create inflammation. It's not going to get there anymore. So all of a sudden, the patients start having improvement in their knee symptoms. And the only way we know that is because we actually give the patients a score. It's like a scoring questionnaire. And you're going to tell us how much pain you have. And when you come back at a month, and at 3 months, and at 6 months, what we see is that the score that you are giving us is lower and lower and lower. So we're not making this stuff up. The patients are. The patients are the ones that are telling us that this is actually working. And it makes sense. All what we're doing is treating the inflamed areas and depriving it from all of the things that it needs to continue to be inflamed. So it's we've seen a tremendous response from this type of procedure. So always get asked, well, who is a candidate, right? Well, anyone who has a bum knee. It has to be osteoarthritis, right? There are a lot of knee conditions that cause pain, but it needs to be degenerative arthritis. That is the one that we know that this particular procedure helps with. You have to have chronic pain. Most patients should have had previous treatments and injections, steroids and hyaluronic acid, and at some point you must have had an x-ray that shows osteoarthritis. When we see a patient, we try to put you into one of three categories for treatment. One is, I think this works well for patients who are not a candidate for a knee replacement for whatever reason. Medical or anatomical, or because you've had it before, if you're just not a candidate to have the operation, then that is one group. The other ones are those who may want to delay the surgery. Because I have to say that the real treatment for osteoarthritis, the permanent, definitive treatment for osteoarthritis pain, is surgery. It's a total knee replacement. But in lieu of that, then a procedure like this will help you kind of cope with the pain and allow you to be more active. So if you're trying to delay the knee replacement for whatever reason, then that will be another option. Even patients, we've treated patients who have already had a knee replacement and they have gone back to having more pain again. which means that maybe you are now due for another knee replacement on the same knee. So sometimes we help with that as well. Who do we not want to do this procedure on? Well, patients who are already scheduled for your surgery. If you come in and says, oh, my doctor said that I'm good, I have it scheduled for next month, but I wanted to try this first. And they said, no, that's not the way. You're going to have your knee replacement, okay? Because as I said before, the best treatment for the problem is a knee replacement. And if everything is already in play for you to have it, you should have it. Patients who have had previous failed procedures like this, if you've had it a couple of times and it's just not working for you, maybe it's a good idea not to keep on doing it. If you have cancer or localized infection or any other condition of the knee, then we won't do it. And we will not do it for patients who also have severe PAD, right? If you have significant arterial disease, then that may not be a good idea to go in there and potentially cause other problems. So when we do this, the pain will improve. That is the expectation, okay? But you are not, the patients are not going to be completely pain-free, even though some people have said that they don't need any pain medication, that they move around like it was before. But the reality is that the goal of this procedure is improvement. Okay, we're not getting rid of the condition. We're not making this magically go away. So I tell that to patients all the time. As I mentioned before, the mechanical pain will only be fixed mechanically with surgery. And at the procedure or after the procedure, there will be actually more pain initially. Because once we do that, we create sort of a brief initial jolt of inflammation because the body is trying to figure out what is happening here after this procedure. The first few days it hurts, I want to say maybe 2 to 5 days, and then starts fading away, and then is when we see that patients come and say, wow, this is amazing. We have measured 25% reduction of pain just within the first week, and then an additional 10% per week up till about 75%. And this has been shown to last up to 6 to 9 months. Some people have reported improvements up to 2 years. So at this point, I would like to thank you for your attention and for having us here. Happy to entertain any questions of any kind about what we talked about here or not. Just come and reach out. I'll be here lingering for a little while. Thank you very much.
Hi. I wanted to know about the knee injection. Is it the steroid or the steroid injection that they give to the knee or cortisone? What is the difference between the cortisone and the steroid?
Between the cortisone and a steroid?
Yeah, the steroid.
Cortisone is a steroid injection.
Okay. So
that's not what we talked about.
I know.
Yeah.
But that's my question. That having that and what you're talking about, what is the difference?
So cortisone injections are anti-inflammatories, right? The steroids are anti-inflammatories. So what is done with that is that they actually go and inject inside of that space, right? Yeah. The space between the two parts of the knee.
Yes.
Right inside of that space, they inject the anti-inflammatory with the hopes that the anti-inflammatory is going to get in there where the inflammation is and kind of, settle that down a little bit. But just like any other medication, the effect of the medication passes. So it'll last you a couple of weeks. It'll last you, maybe 4 weeks or 6 weeks, but then it's gone. Okay, so it's a real short-lived temporary fix. Now, this is not what I discussed. This is completely different approach, completely different mechanism of alleviating the pain.
Yeah, that's why I asked, because I've been having the injection, so I know.
Yeah.
So that's why I wanted to know the difference, if you have the injection, can you do that? After you've been having the injection that it doesn't
We do it all the time, because who hasn't had injections? It's like everybody has had injections. They've had it for years, right? And why you have so many injections? Because the stuff does not, the effect doesn't last, right? So honestly, the expectation is that this or something like this will eventually replace those knee injections. Why? Because if you get a treatment and you get a good result, you may be free of pain for a year. Right?
Yeah.
So if it works, and if you go from being incapacitated because of your pain, and then all of a sudden you go back to just normal mobility and not taking any pain pills for about a year, that beats any injection that I know of. So the people that is really looking at this very, very seriously and compiling all the data said that this is going to be what most people are going to be trying to get, as opposed to the knee injection. Again, if it is appropriate, okay, and if you are in one of those categories that, you know, where you are really supposed to have this type of procedure. If you are not, then maybe you will need to have a knee injection.
Hi.
Hello.
Does this procedure also work on osteoarthritis of the patella?
Of the patella? Well, the patella is part of the knee, and the patella is actually floating around in a separate place. So osteoarthritis of the kneecap, I don't think that is what would cause the issue. If you or someone you know has that, I wonder if there is something else. Because the patella is surrounding in a sac of fluid. So if it's hurting, maybe it's because that whole area in the sac of fluid is having a problem. And I don't know if this will help with that. Okay? Because osteoarthritis affects the joint. The patella only floats around the joint. Okay? So it's really not causing pressure on the bone or, interacting with the joint that way. But, granted, I have heard of that before, but I don't know if this will help in the same way. Because we like to treat the problem that is being caused for that bone-on-bone situation, right? That's sort of the one that I think benefits the most from this.
Thank you. I'd like to know the success rate, and I'm almost there, for people 80 and above.
I just don't know how this works for people that are 18 and below. In other words, everybody is elderly, right? Everybody that gets this procedure is obviously aged. This is not a procedure for young people. The reality is that this is the simplest and the lowest risk procedure that we do. And I do a whole lot of other things, much bigger and horrible things, to 80-year-olds all the time. So this will not be it. This will not be the procedure. Now, no one has asked me yet, what happens if I do want to have a knee replacement and I've had this procedure? Is this going to interfere with the surgery, or is this going to interfere with my healing after the knee replacement? None of that. Okay? This will not change at all the ability to have a total knee replacement if you've had this procedure done. Okay? And there have been multiple studies that have looked at this. I'm just not making this up. Okay?
Hi.
Miss.
How do you treat lymphedema?
Lymphedema, well, it depends, right? Just like everything. It depends on why you have the lymphedema. A lot of patients come in to see us because they were told they have lymphedema, and they have a number of things other than lymphedema. So it is important to really know if what is happening is true lymphedema. And there are multiple reasons for patients to develop that. But the treatment for lymphedema is non-surgical, right? So there's no procedure that I can do to make that go away. If anybody has lymphedema, the treatment for lymphedema will be the same treatment as for any other type of edema, okay? If it's venous edema, or if you have lipedema, or whatever other types of swelling that you have in the legs, the treatment is going to be the same, which means you need to have compression in your legs, like compression stockings, like Jeannie pointed out, elevation of the legs, physical exercise and activity with your legs, and weight reduction or weight control, right? You don't want to put on weight, right? The more weight we put on, the worse our legs will get. So that is it. There is no surgical treatment for lymphedema that actually works. A lot of people have tried things, but none of that really works if you have or you know someone who has primary lymphedema. In the back, yes, sir.
Can you tell us anything about elbow pain?
I have been asked that before. That would be nice, huh?
Yeah.
This has not been tested on that. So we don't know how that would do for elbow pain or hip pain or shoulder pain, right? We don't know how that works. So I don't know. Maybe we'll talk again in the next 5 years, right? This is constantly changing, right? Just like everything in medicine. It's constantly changing and constantly improving. So I'm sure that there will be many iterations and treatments and applications for other things. Yes, ma'am.
I have a client here asking what the cause of numbness after small exercises in the legs. The numbness?
Numbness?
Yeah, numbness.
So he has numbness after exercise. Yeah. So that could be a number of things. Usually not a vascular problem. Okay? I think what I find is most patients that come in to see us for numbness is actually because of a nerve-related problem. Usually those problems come from having pinched nerves or other nerve-related conditions that lead to the numbness. And usually numbness is not a lone symptom. If it is a nerve problem, then you're going to have, yes, numbness and tingling and burning and pins and needles and all of these things.
Well, thank you so much, Dr. Somoza and Ginny Rose. Thank you so much.
Thank you all very much. I appreciate the time.